Hello, everyone. Thank you for coming to our abstract session in pancreatic cancer. I would like to ask everyone to take your seats. We have a busy schedule coming ahead with 8 excellent talks. Each talk will be 10 minutes, and we ask the speakers to try to discuss their topics in about 7 to 8 minutes. And after each talk, we're going to have time for 1 to 2 questions. We're going to start today's discussion with Dr. Thur Singh. He's a professor of pathology at University of Pittsburgh, chair of cancer genetics, and co-director of the pancreatic cancer research at UPMC, among other titles. Dr. Singh, welcome.
Thanks. My name is Thur Singh. Thank you for the introduction. I have no relevant financial relationships to disclose. With frequent use and improvements in abdominal imaging, incidental pancreatic cysts are commonly encountered. It's reported that pancreatic cysts are identified in up to 3% of abdominal scans, and this prevalence increases with age. Many cysts, including serous adenomas, are benign and can be monitored clinically, while mucinous cysts, such as IPMNs and MCNs, and actually now simple mucinous cysts in the WHO, have the potential to progress to invasive adenocarcinoma. As the management and follow-up of these cysts are different, an accurate preoperative diagnosis is truly critical. Therefore, EUSFNA of pancreatic cysts has become particularly important. But imaging and ancillary studies alone, such as CEA and cytology, have had limited success in cyst classification. More importantly, prognostication, as not all mucinous cysts will undergo malignant transformation in the patient's lifetime. Recently, the application of molecular techniques such as next-generation sequencing has become very important adjunct to the evaluation of pancreatic cysts. In fact, in a multi-institutional study evaluating the diagnostic performance of the NGS panel known as Pancreatic, a 22-gene panel that was offered to over 30 institutions and tested over 1,800 patients, found that it achieved a sensitivity of 90% and a specificity of 100% for mucinous cysts, superior to fluid viscosity and CEA testing, and an 89% sensitivity and 98% specificity for advanced neoplasia, superior to clinical, imaging, and cytopathologic evaluation. Since the conclusion of that study, Pancreatic has been updated to a combined DNA and RNA next-generation sequencing panel known as Pancreatic Genomic Classifier, or Pancreatic GC for short, and evaluates over 5 classes of genomic alterations and expands on its ability to classify various neoplastic pancreatic cysts, along with improving the detection of advanced neoplasia. However, Pancreatic GC has not been compared side by side with the original version of Pancreatic, nor really validated for the most part to determine if any improvement in diagnostic performance is truly achieved. Therefore, we initiated 2 investigator-blinded retrospective studies. The first study was to evaluate a multi-institutional cohort with diagnostic pathology collected over the course of 2 decades. The second study was to evaluate the prospective observational cohort that I just discussed that demonstrated the original version of Pancreatic could improve the evaluation of pancreatic cysts over traditional diagnostic modalities. The first study, Pancreatic GC, in the first study, Pancreatic GC achieved a 92% sensitivity or a 4% improvement in sensitivity for mucinous cysts as compared to the prior version. In addition, it showed a 23% improvement in sensitivity for advanced neoplasia. But it's important to highlight that the overall sensitivity for both assays was substantially lower than expected as compared to what was previously published for the original version of Pancreatic, and I'll get into exactly why. The second multi-institutional study evaluated our prospective observational cohort for the original version of Pancreatic, and while this cohort was collected over a smaller time cohort, it retrospectively used a pancreatic cyst fluid preservation buffer called PancPreserve. It ensures nucleic acid stability as well as high DNA and RNA quality as well as yield. Similar to study 1, Pancreatic GC again showed increased sensitivity for mucinous cysts, but more importantly, a sensitivity of 87% for advanced neoplasia. Further, the overall sensitivities for both assays were higher as compared to study 1, and what was expected based on our previous studies and experience with next-generation sequencing of pancreatic cyst fluid. However, to answer the question of diagnostic improvement for Pancreatic GC as compared to Pancreatic, within this study, a statistically significant increase in sensitivity was achieved as per McNamara's tests for both the identification of mucinous cysts and the detection of advanced neoplasia. And so in summary, you can't really discuss a ton of things in 7 minutes, but I hope I've impressed on everyone that the application of next-generation sequencing to pancreatic cyst fluid is an important adjunct to the preoperative classification of pancreatic cysts and early detection of pancreatic cancer. Furthermore, Pancreatic Genomic Classifier, or Pancreatic GC, as a combined DNA and RNA assay, shows statistically significant improvements in sensitivity for mucinous cysts and advanced neoplasia as compared to the original version of Pancreatic in 2 independent studies over a significant timeline. I would also like to stress the improvements of specificity because of that really RNA component of Pancreatic GC, which is only possible because of the ability to stabilize the nucleic acids. And really to highlight the significant decrease in performance with the first multi-institutional study when you don't really use that cyst buffer itself. And really, honestly, that pancreas preserve itself, it really preserves the nucleic acids from the inherent issues with the pancreas, and that being trypsin, chymotrypsin, and lipase, and a real necessity. But the honest truth is, the true evaluation, or rather the diagnostic performance of Pancreatic GC, will only really come from the multi-institutional study that's still currently ongoing, with a data analysis comprising of over 50 institutions and over 12,000 patients, which we hope to complete within actually this year and the beginning of next. And with that, thank you. Happy to take any questions based on time.
We have time for a number of questions.
Yeah, thanks a lot, Arthur. This impressive data as usual. For the improvement in sensitivity, so the Pancreatic GC, I'm assuming, detected a few additional cases that were not detected by the original Pancreatic. Were there any factors that led to that improvement? If you look at just those cases, were there any predictors that would make a selection of one test versus the other?
Right. So there's multiple differences when it comes to Pancreatic versus Pancreatic GC. One is going from a 22 gene panel. The other one is a 74 gene panel. However, probably the highest improvement is because of the RNA component of Pancreatic GC, and that's the identification of fusion genes, which are associated with high-grade dysplasia and cancer.
Okay, thanks.
I have a question.
Yeah.
Were you able to collate radiographic indicators from these patients to correlate to the transcriptomic analysis?
So that's actually a very good question. We have looked at basically worrisome features, high-risk stigmata. Those tend to underperform as compared to Pancreatic GC.
Thank you. Anyone else?
In the by adding the RNA to the panel, did you also look at gene expression, and was that any signature that was relevant for the diagnosis?
So gene expression is part of Pancreatic because it looks at 5 different analytes when it comes to DNA and RNA, and that gene expression actually includes keratin expression. So looking for if it's an epithelial line cyst that should express keratin as opposed to a pseudocyst. And that is useful from the point of view of looking for a mucinous cyst and that being a neoplastic one.
Any other questions?
Sorry, I may have missed it. It's a good presentation. Did you distinguish between mucinous cysts and IPMNs?
Mucinous cysts and versus or what?
Between mucinous cysts and IPMNs.
So you're actually referring to mucinous cystic neoplasms
Yes.
versus IPMNs.
Yes.
Mucinous cysts is the global heading for IPMNs, mucinous cystic neoplasms, and simple mucinous
Yes.
cysts.
Did you distinguish between the two?
So yes, we did.
And what was the difference in performance?
So unfortunately, this has been shown repetitively over and over with DNA-based testing, is MCNs unfortunately can harbor no KRAS mutations whatsoever.
Yes, we know that.
And
That's why I've asked the question.
So that's the limitation, right?
Okay, thank you.
Okay, thank you.
Yeah.
Okay, moving on, our next presenter is Nicole Lester, who's from William Hong's lab at Mass General, and she'll be presenting her work on integrating spatial biology and peripheral blood biomarkers in pancreatic ductal adenocarcinoma. Nicole.
Thank you very much. Thank you very much for the introduction. I'm really excited to be presenting my work here today. So to begin, I'd like to give a brief overview of spatial transcriptomics. So the figure we see here nicely summarizes the current spatial technologies available, which can broadly be divided into sequencing and imaging-based methods. So with the sequencing-based methods, we have high molecular panels easily reaching the 1,000 and whole transcriptome level because the RNA sequence itself is actually acting as a unique barcode. But the trade-off for these higher plexes is lower overall spatial resolution due to larger capture spots. And on the other hand, with our imaging-based methods, we're actually able to achieve subcellular resolution, but are physically constrained by how many distinct fluorescent signals can be resolved in crowded tissue spaces. So the trade-off is lower plex for higher spatial resolution. But what if we're able to combine the best of each of these techs and break the conventional plex resolution trade-off? We're actually able to do that with the CosMx Spatial Molecular Imager, or SMI, and we're actually able to profile the entire transcriptome of tissue in an imaging-based manner with subcellular resolution. And why is it so important that we achieve this type of coverage? Well, with the current 1,000-plex panel in the SMI, we're actually only able to cover about 22% of all known genes participating in ligand receptor interactions. And this really limits the type of discovery-based research that we can do. And on the other hand, the whole transcriptome covers all known and unknown genes participating in ligand receptor interactions. And this profiling in this unbiased manner enables us to do true discovery-based research because we're no longer constrained by preset panels. And this is really cool. This allows for the discovery of new ligand receptor interactions, new and rare cell states, and the identification of treatment-resistant and responsive populations, which is particularly important in a disease like PDAC, which is very treatment refractory. So we decided to apply this SMI to a cohort of patients that we've been collecting samples on collecting samples on throughout the course of their standard of care treatment. And this is outlined in the timeline above. So these patients are biopsy confirmed to have pancreatic ductal adenocarcinoma, and they undergo neoadjuvant chemoradiation followed by surgery. And I want to emphasize how powerful this protocol actually is because everything's patient matched and temporal. So we're able to glean a lot of insights about the tumor microenvironment and how it's changing throughout the course of treatment and do some really phenomenal correlated tissue liquid biomarker analyses. So what we did is we used the CosMx SMI to profile consecutive tissue sections at the 1,000 plex and whole transcriptome level. And then we analyzed our plasma in two ways. One through cell-free RNA analysis, and then we profiled the inflammasome. So here we have one of our patient-matched samples. We have the pretreatment biopsy at the top and the post-treatment resection at the bottom. And we use the annotated H&E to guide our field of view, or FOV selections, to select areas of tissue we want to spatially profile. And we're doing this paired spatial profiling on consecutive sections because we want to ensure that we're capturing the same tissue area for both panels so that when we go to map between them, we know that we're annotating roughly the same cells. And the reason that we're using the 1K SMI is because it allows for really reliable cellular annotation capabilities. Although the whole transcriptome has really high coverage, it causes transcripts to be detected at lower levels, thus making annotations more difficult and less reliable. So basically what we're doing is we're integrating and using the 1K panel to guide our annotations for our whole transcriptome. And we're able to do this with a method we developed in-house called spatial transfer to enable label annotation, or STELLA. Okay, so STELLA is this two-step annotation process that involves starting with our SNOOC-seq reference, and we identify anchor cells within our 1K SMI data. We generate a reference and then do some supervised clustering with in situ type. We're able to then integrate these annotations from the 1K to the whole transcriptome data and do a label transfer. And the result is this really beautiful UMAP we see at the bottom right. We're able to identify different cell types like epithelial cells, fibroblasts, endocrine cells, macrophages, Schwann cells. And once we have these cell types annotated, we're able to do some really phenomenal analyses. We can analyze these cells at the global, regional, and cellular level. At the global level, we can do histopathological analysis of the H&E. We can look at specific phenotypes and morphologies within the tissue microenvironment itself. We're often looking for things like residual cancer regions, nerves, remodeled tissue, tertiary lymphoid structures, and we're often able to track these structures to signatures we see in our spatial data. We can do neighborhood analyses to understand cellular niches and understand populations of cells that are jointly signaling with each other. We're able to do something called spatial NMF, which essentially allows us to distill spatial gene expression into programs based on similar expression and spatial location. On the left here, we see some of our top programs mapped back onto the tissue. And on the right, we have the normalized activity of one of our top programs, program 1, also mapped back onto our tissue. And then we're able to annotate at the cellular level. And we do this with a method called SCOTIA, which we developed in-house and published a paper on. And this is using this, we're able to look for enrichments of broad signaling pathways or specific signaling pathways between pre and post-treatment samples. And what we found in our data is we found an enrichment of signaling between cancer-associated fibroblasts and cancer cells in our treated samples. And so while we get really great spatial insights from this data, we're limited to just the pre and post-treatment samples. We're lacking the full picture of the TME evolution during treatment. And this is especially important during events like recurrence. We want to know what's happening at the TME level so that we can treat our patients. And so this is what really drove us to look at the plasma biomarkers. We want to understand what's happening at those other time points. And from a feasibility standpoint, serially sampling a PDAC patient is just not going to happen. It's too painful. It's too invasive. So this is what really motivated us to pursue these plasma biomarkers and see if we could capture signatures in the spatial data in a peripheral manner. So what we're doing is we're doing cell-free RNA analysis using RareSeq in collaboration with Max Steen over at Stanford. And then we're profiling the inflammasome by profiling 1,000 inflammatory proteins using Nomics Omni 1000. And what we found was really exciting with our cell-free RNA data. We find an enrichment of expression of the classical subtype markers in our untreated samples. Which then shifted post-treatment to an enrichment in our mesenchymal-like signatures. And we also, in the post-treatment setting, see a decrease in our classical-like signatures. And this is really important because in PDAC, we know that classical and basal mesenchymal-like cell states are both prognostic and predictive. We know that patients that have classical-like cancers often respond better to treatment and have better overall prognosis compared to patients that have more basal mesenchymal-like cancers. And so we were really excited to see this recapitulated in our own data and the pre-existing literature. So what we're doing is we're analyzing other treatment time points. This is a very small cohort we did of just 4 patients. So we're now profiling the rest of these patients at other time points to better understand what these subtype shifts looked between different treatments. And then finally, we have our plasma proteomics data. Here we have pancreas-derived enzymes, PRSS1 and CTRC, which we know are associated with pancreatitis. They're highly expressed in the pretreatment setting, but eventually decrease over time, course, which is indicative of a reduced overall inflammatory state. And we're actually able to recapitulate these enzymes in our spatial data as well. And what's really interesting about this plasma proteomic data is that we're actually seeing a stratification of patients. We're seeing subsets of patients that are similarly expressing some of these proteins. So what we're doing is we're interrogating the prognostic value and features of these proteins to see if we can identify any clinically relevant biomarkers of treatment response or prognosis, for example. So to quickly summarize, I know that was a lot. We discussed the importance of whole transcriptome, spatial whole transcriptomics and discovery-based biology. We discussed the importance of temporal sampling of patients throughout treatment course and how it enables us to do causal inference analysis. We showed that integrated 1K and whole transcriptome data enables an accurate cellular annotation and allows us to do deeper analyses. And finally, we identified and recapitulated biomarkers from our spatial data and peripherally in the blood. And as the spatial and peripheral data set is built, we can expand this to all other cohorts. This is just a framework. This can be expanded to other cancer types and diseases, but what I'm really interested in looking at is high-risk PDAC patients. So moving towards patients that have IPMNs, chronic pancreatitis, people that are really predisposed to developing PDAC, and seeing if we can identify any peripheral early identification markers. And so with that, I'd like to thank the Kenner Family Research Fund and the APA for the opportunity to present this work, the patients who participated in this study, my wonderful PI, Dr. William Hong, Beatrice Awasi, Dennis Olga, and Martin Hemberg for their amazing work on this on the computational side, surgeons, Radongs Fellows, our collaborators at Nanostring and Nomic. Thank you very much.
Thank you, Nicole. We have time for one question. Ma'am, I'm sorry, we have time for one question.
Thank you. I'm Richard Waldron from Cedars-Sinai. We're also doing spatial transcriptomics and other spatial techniques. We don't have as many bioinformaticists as you guys do.
Yeah, we have a lot of them.
We're using geomics, not yet cosmics. We also have cosmics at Cedars. But my question for you is, really, do you feel that you're interpreting those data correctly when you look at PRSS1 and see TRC in the blood circulation, and you see it going down, and you see that as a good thing?
Well, I think that increased expression of those enzymes is telling us that we see an inflamed pancreatic state. So the decrease, I mean, these are just initial analyses. So what we're planning on doing is normalizing the levels and looking at how those normalized expression levels change over time.
Because I would push back on that and say that if the PDAC was progressing and destroying the pancreas, you'd also see decreasing amounts of digestive enzymes in the blood.
Yeah, that's a really fair point. I think at this point, it's because our cohorts are still so small and our spatial data, we only have a sample size of about 9 patients at this point. It's really hard to glean any robust insights and correlate those spatial data points that we found with the peripheral biomarkers. So yeah, it's just very preliminary. I know it's not a very good answer.
It's okay, because the basic issue is we simply do not have a platform. We do not have an understanding of why certain proteins are in the blood.
Right.
Are they unmoored from their organs, or are they on their way somewhere? These kind of things are just simply not in our understanding yet. But thank you for a very nice study.
Oh, thank you.
Thank you, Nicole.
Our next speaker is Dr. Anup Mishra, who is Assistant Professor of Biomedical Informatics at Mayo Clinic, and he will be speaking about combining rules-based natural language processing and large language models for automated extraction of familial and genetic risk factors in pancreatic cancer.
Thank you so much for the introduction. Thank you for the opportunity to speak at this conference and share our research. I do not have any disclosures. Pancreatic ductal adenocarcinoma is an uncommon yet lethal cancer, but we don't have any general population level screening at the moment. But there are clinical paradigms that define somebody as a high-risk individual if they have a lifetime risk of PDAC exceeding 5%, and that is based on family history of PDAC in first and second degree blood relatives, and pathogenic or likely pathogenic germline variants in PDAC susceptibility genes listed here. However, despite those guidelines, 80% of high-risk individuals, those are eligible for PDAC screening, are not enrolled in a surveillance program. This is due to several challenges, including these risk factors are often embedded in the clinical notes of EHR and not very easily accessible. Primary care physicians are often unfamiliar with these risk factors, and manually identifying these risk factors is time consuming. So we have approached to solve this problem using AI. Hence, the aim of this study is to measure real-world performance of AI algorithms in extracting these risk factors from clinical notes in a primary care population. Previously, we developed a rule-based algorithm that focused on extracting these risk factors in an enriched cohort. But here, we have improved that algorithm by adding novel natural language processing models and newer AI models, such as large language models, and utilize that to validate in a larger primary care cohort. We collaborated with 19 primary care physicians and identified 3,500 patients randomly from their patient panel. Those were aged 18 and above with Minnesota research authorization. All charts were manually annotated by clinicians and research coordinators, and the cohort then was split into development and test set for AI model development and validation. We chose a sample size of 3,500. That's based on an estimation that assuming 5% documented PDA risk factor prevalence and performance of our previously developed rule-based model. We chose a larger test set so that we can ensure that there are adequate positive events in the model validation, so robust model performance. And we chose patients from 2 different practice locations to ensure that there is a diverse patient population from rural setting and urban setting. And finally, the models were validated using positive predictive value, sensitivity, specificity, and F1 scores. In the next few slides, I'm going to share 4 different model architectures, 2 rule-based models and 2 hybrid models. The rule-based models are combined with large language models to build the hybrid models. Here in this example, we are extracting the family history of PDAC using a rule-based models. What we do is we use all the available clinical notes of a patient, run them through the rule-based model to identify notes. Those have any family history of a patient with PDAC, and then we identify patient level results who have for the patient, those have family history of PDAC. Next, we challenge all the positive results identified by the rule-based model, and then we also challenge it using a large language model, and then also use the large language model to extract additional positive instances that are missed by the rule-based model. We combine them using a set union operation to find the final set of positive instances with patient with family history of PDAC. Finally, we also observed that some of the patients have their family history of PDAC embedded in the structured format in the clinical notes. So we extracted them using a SQL script to get the final set of patients with family history of PDAC. Very similar to what we did in the family history extraction using rule-based model, we did the same thing for germline variant extraction. What we observed is the rule-based model for germline variant extraction often missed or couldn't decide between the somatic versus germline variants, which resulted in a lot of false positives. So all the positive nodes identified by the rule-based model were then run through a large language model to identify the final list of positive patients with germline variant as positive. This table represents patient characteristics and of the cohort, and I would like to highlight that it's important to note that only 5%, about 5% of individuals had any of the risk factors, which is similar to what we assumed for our study, aligns with what we assumed for cohort selection. In terms of the test set model performance, we observed that the rule-based model for family history extraction performed with a high positive predictive value, sensitivity, specificity, and F1 score. When we added the hybrid model, we had an improved sensitivity, and that's because the rule-based model missed a few of the positive instances that was captured by the hybrid model. In germline variant extraction, the rule-based and the hybrid model both had higher sensitivity and specificity, but the rule-based model had a lot more false positives that were improved by the hybrid model, so we have a better positive predictive value here for hybrid models. It's critical to note that only 5.8% of the population had any of the risk factors, and out of them, only 0.1% had met high-risk individual criteria. What that means is for a primary care physician has to review charts for 3,000 patients for over 100 hours to identify only 3 eligible patients for PDAC surveillance or screening. Hence, it is important to think that an AI model, such as what we just built in this project, would help in identify those individuals, those are eligible for screening in a fraction of time. Additionally, 90% of the individuals who had a first-degree relative with PDAC had no prior germline testing. And that reveals a clinical gap that there are many potential high-risk individuals remain untested for germline variants. In conclusion, I would like to share that to our knowledge, this is one of the first large-scale investigations to extract these PDAC risk factors, such as familial and genetic risk factors, from clinical notes in a primary care setting. The AI models could accurately extract these PDAC risk factors, and the findings support practical use of AI in guiding genetic testing, risk stratification, and optimizing referrals for PDAC screening. And finally, in future direction, we would like to validate this in larger, diverse cohorts and perform a clinical implementation of the model. With that, I would like to thank everyone for your time and attention. And this is our wonderful team. I would like to thank the team too, and led by Dr. Shaunak Majumdar at Mayo Clinic. I'll be happy to take any questions.
It's a very nice study and actually going to be very useful clinically. It looks like you're using one LLM though, and that being Gemini. Have you tried using different models themselves? And then are you integrating this into Epic, or do you have to do this outside of Epic as an academic?
Sure, those are great questions. So at Mayo Clinic, so the research shows that these LLMs have like they saturate at some point in terms of performance. And when you use Gemini, based on research, you would see they perform very similar. At our institution, those are the models, those are PHI approved because we're looking into PHI data. We haven't tested all the models, but would assume that they would perform very similar. And in future, we are planning to integrate that into Epic, and there are different ways to do that. And we're still exploring how we would do that.
That's a quick question. Phil Hart, Ohio State. This is really nice. Congratulations. It's always nice to see when technology can be used that would make physician work less. I could also see this be really helpful as sort of the rules or the eligibility criteria for HRI shift.
Sure.
It could really be a huge service for all of our institutions. Simple question is, did you look to see, or do you know off the top of your head the number of how many of these patients may have been identified by, say, ICD coding for family history of pancreatic cancer, or a rudimentary query of a genetic database at the institution?
So out of the 3 individuals, those met high-risk individual criteria, only one of them was in the surveillance, already in the surveillance, and 2 of them were not, right? But it is hard to say if any of them were identified by physicians or screened, right?
Yeah, maybe clarify my question. My question is, if you were to go through Epic or whatever, EMR we have at our institution,
Right.
and to do an information warehouse dump when you just program and say, hey, give me everybody with a family history of pancreatic cancer, which may not pick up if somebody, narrates it in the HPI or whatever. How many of these patients would have been identified through that more sort of rudimentary sort?
Again, I'm not a physician. I never use Epic. And so I wouldn't know. Dr. Majumdar is here. He might have a better answer for that.
Because I guess the question, the heart of the question is the juice worth the squeeze? In other words, if you're going to identify, a fraction
It's
of a percent of the
definitely
3,500,
hard.
could you just query the entire institutional database for family history, and would you maybe get similar results?
I'm
Or
gonna
what's the
cut off
intent
to
of
answer that. So we're gonna have one more question here. You guys can have that conversation offline. Thank you. Last question. Thank you.
Congratulations, great presentation.
Thank you.
So you've identified some high-risk individuals, which is great, and then you want to take that further. How do you deal with the general data protection regulations from a practical point of view?
So
These people haven't given consent.
that's a
So,
good.
so how then do you deal with it?
That's a great question. So in Minnesota, we, especially at Mayo Clinic, individuals who are consented were only part of the research, because there is a Minnesota research authorization. Everybody who accepted to be a part of research at that institution were part of the study. But in terms of clinical guidelines, if we identify the risk factors and show it to their primary care physician, we're not necessarily, this is like any other Epic tool that's already integrated. So we're not sending them anything directly. We're just sharing that with their primary care physician so
Well,
that they
that's-
can.
Yeah, you're still breaking the law. So this needs to be, it's an important issue, this, because it is slowing down research across the board for pancreas cancer and other, other situations. That this needs to be taken to a high level so that we can do something about GPDR, for this kind of work that you're doing.
Absolutely.
think-
This is still in the research setting, but when
Yeah,
we
yeah.
eventually think about implementing, we'll definitely reach out to the higher, leadership that helps implement any of the clinical tools in the EHR. So thank you. That's a great question.
Thank you for those comments. We're going to move on.
Just a reminder, if you come to the microphone, please stick to one question and then follow up afterwards. Appreciate that. Okay, next we're going to have Soban Man, a postdoctoral fellow at West Virginia University, presenting EUS-guided radiofrequency ablation of celiac ganglion using a novel RFA needle for pain management in patients with pancreatic cancer, a pilot study. Soban, thank you.
Hello, everyone. So this is US-guided radiofrequency ablation of celiac ganglion using a novel needle for pain management in patients with intractable pain secondary to pancreatic cancer. This study was conducted at West Virginia University under the guidance of Dr. Shyam Tucker and Dr. Shalindra Singh. And yeah, these are the disclosures. So just some background. Pain management in patients with advanced pancreatic cancer remains a challenge. Interventions like celiac plexus neurolysis can be used to control pain and improve quality of life without the risk of opioid-induced side effects. Studies utilizing endoscopic ultrasound-guided celiac plexus neurolysis using the alcohol injection have shown wide variations in pain control outcomes, most probably due to variations in interventionist technique and the lack of accurately targeted neurolysis, which limits the efficacy of the procedure. So the background is the radiofrequency ablation RFA is a high-frequency alternating current pulse that causes thermal coagulation of tissue. Percutaneous RFA has been utilized effectively in inducing splanchnic nerve blockade in patients with abdominal pain. More recently, EUS-guided RFA has been utilized for ablation of neoplastic lesions. And so this led to the current study that EUS RFA using novel probes can potentially enable highly focused targeting of the celiac plexus and may be useful for pain management in patients with pancreatic cancer. Our aims were, we basically hypothesized that EUS-guided RFA of the plexus could be utilized for pain management in these patients. And because of its potential to provide real-time focused targeting with reliable and consistent ablation. And it was a pilot feasibility and safety assessment that we conducted using this novel needle. The study was conducted at Ruby Memorial Hospital at West Virginia University. This was a prospective single-arm open-label trial, prospectively registered at clinicaltrials.gov. We included patients with advanced pancreatic cancer and intractable pain that was refractory to multiple escalations of opioid medications. We excluded patients younger than age 18 and those with coagulopathy. So these are some procedure details. All patients underwent EUS RFA using a novel needle, which is a dedicated 19 gauge needle with a 5 mm RFA capable tip. It's shown at the top left. Ablation was performed at 10 watts under endoscopic ultrasound guidance. Ablations were stopped when an impedance threshold of 400 to 500 ohms was reached, or the ablation timed out at 25 to 30 seconds. Briefly, this threshold was set to prevent charring of tissue, because if it goes on long enough, it heats up the tissue and there's a risk of possible unnecessary damage and like tissue vaporization. And there's a tube of chilled saline that continuously circulates chilled saline throughout the probe through the procedure to avoid overheating. That's an additional safety mechanism. Can you play the
Here's a
video?
I don't know if you can. Is that a no on the video?
Yeah, this basically just shows that like the hyperechoic area there labeled as the celiac ganglion is directly visualized, and then the endoscopist will probe it with the RFA needle. And once it's probed, and then the ablation will start under direct visualization of the ganglion or AUS guidance, and he'll ablate it until the entire visualized area turns hyperechoic. Moving on. Our primary endpoint was improvement in the pain severity score as measured by the pain severity subscale of the brief pain inventory form. And we further subcategorized the outcome as into two categories. One was mild improvement, which was a 1 to 3 point improvement on the pain scale, or a de-escalation of opioids. And the second was considerable improvement. That's more than a 3 point improvement on the pain scale, coupled with a de-escalation of opioids. These are the patient characteristics of the 19 patients we consented for participation in the study. And out of these 19, these are some procedure details. The median number of ablations was 12. The median ablation time was 167 seconds. And one patient was lost to follow-up. The rest remained available for follow-up. So one important detail is that out of these 19 patients who were consented, the procedure was performed in 17 of them. So 89%, because the procedure was not attempted in 2 patients, because once the probe was in the intervening blood vessels precluded the direct visualization of the ganglion, which was main focus of our study. We wanted to visualize it before initiating the RFA. So no intra-procedural adverse events occurred throughout these 17 procedures. No serious adverse events were reported throughout the study. One patient reported mild rib pain at 2-week follow-up, which was managed conservatively. So coming to the primary outcome, 11 out of the 17 patients in which the procedure was performed reported improvement and met the outcome threshold that we outlined previously. So mild improvement was noted in 5 and considerable improvement was noted in the other 6. So our conclusions based on this is that EUS RFA of the celiac ganglion using this novel 19-gauge RFA probe is a technically feasible and safe alternative to conventional celiac plexus neurolysis. The celiac plexus ganglion, if visualized, can be precisely targeted under EUS guidance, and the procedure enables real-time feedback, not only visually, but also on like soft tissue impedance through those threshold measurements that we discussed. But obviously further studies are needed to refine and optimize the procedure technique. And some limitations are that it was a single arm design, so there was no comparison group. There was a lack of long-term follow-up. We only assessed the outcome at 4-week follow-up, and there was a lack of self-reported patient outcomes like quality of life questionnaires. So that's it. That's our team. Yeah, this is an upcoming WISE conference. This is the WVU Zone Interventional and Surgical Endoscopy Conference coming up next year, and we would love for you to attend. It's a beautiful resort. Yeah. Yeah, and that's it.
Oban, that was a great talk. I'm a medical oncologist. I'm very interested in learning about new techniques to manage pain in these patients. My experience with the conventional celiac plexus neurolysis has been, hit or miss. Many patients do not get a lot of benefit. I know that this was a single arm study, but can you compare your results, 65% improvement with the historical data on the celiac plexus neurolysis? And can you also comment on the duration of pain relief?
Yep. So while we did not compare our outcomes with the celiac plexus neurolysis group, there's a landmark trial on this topic from 2019 from Orlando Health, and they directly compared the 2 patients in a randomized design. And they found that RFA was more efficacious and like it alleviated pain quicker and in a larger proportion of patients compared to celiac plexus neurolysis. This is probably because plexus neuralysis involves an alcohol injection, which is basically an injection into an anatomic space, which you can't control the diffusion, and like it's not as precisely targeted as the RFA is. And additionally, there is an attendant risk of possible adverse events due to like an inadvertent injury of the surrounding tissues due to that lack of targeted diffusion. So
And the duration of pain control in your study, do you have data on that?
the rates of pain control, yeah, for
Duration. How long was-
duration. Yeah, so that's one limitation of the study, that it was only assessed at 4 weeks. So this would like our results do warrant further larger, well-designed studies that can sort of assess efficacy and safety at like at least 3 and like 6 month follow-up. That would be ideal.
My last question, as a provider who's going to be following these patients radiographically over time, after an RFA, do you see any radiographic changes in the CAT scan or MRI on those patients?
So almost all of these patients had unresectable pancreatic cancer. So that's also one limitation with long-term follow-up, that most of these patients are now deceased. And even if like we we prepare the study in advance a priori to include like even 3-month follow-up would be like maybe half of them would make it that far. So that's a major limitation with that.
Okay, any other questions? Okay, thank you, Soba.
Yep, all the things.
Our next speaker was supposed to be Dr. Julie Young from Mayo Clinic, Florida, but she had problems with uploading her presentation, so we're going to skip her talk. The next talk will be from Dr. Kyung Won. He's a scientist from Cedars-Sinai in Medical Center. Thank you for coming.
Thank you. I'm very happy to have this opportunity to present our work. So as you know, pancreatic cancer has very poor prognosis, and the tumors are usually refractory to the currently available chemotherapy regimens, such as FOLFIRINOX or the combination therapy of gemcitabine and Abraxane. Abraxane is a formulation of paclitaxel. It is nanoparticle albumin bound paclitaxel. As a scientist involved in basic and translational research, I can testify that paclitaxel is a very potent drug in the lab. But for this drug, the problem for this drug in the clinic setting is that it has very poor solubility. And there has been all these different formulations developed trying to solve that problem. At the same time, there's also a constraint on how much we can give to the patient, because high levels of the drug in the plasma is associated with very bad side effects. Now, in the combination therapy of gemcitabine and Abraxane, the two drugs are given to the patient sequentially in the same day. So you start with Abraxane, and that is immediately followed with infusion of gemcitabine. The combination shows better outcomes compared with gemcitabine single treatment, but the benefit is quite limited. We know that paclitaxel is a drug that causes mitotic arrest. It has been shown that this is a compound that can bind to tubulin and stabilize the microtubule network, thereby causing the cells to be arrested in mitosis. Whereas gemcitabine is an antimetabolite that inhibits DNA synthesis and is known to cause S-phase arrest. So when we started the project, we wondered what would happen if you add both drugs to the cell, and how is that going to affect the cell cycle? So we have this flow cytometry-based assay, which allows us to investigate how the cells respond to the treatment of these two drugs how the cell cycle distribution may be affected and whether there is going to be cell death induced. Here I'm showing a dose-dependent response. On the left, it shows the effect of paclitaxel. I would like to point out that at a very higher dose of paclitaxel, the cells are primarily arrested in the G2 and M phase, whereas at a lower nanomolar concentration, what we see is that there is an increase of this sub-G1 population representing cell death, but without any apparent arrest of the cells in the G2 and M stage. On the right side, it shows that gemcitabine causes either rest of the cells in the mid-S phase or in the early S phase, depending on how much you give it to the cells. Now, if we combine the two drugs together, what we observed is that the subpopulation, the sub-G1 population that is caused by low-dose paclitaxel disappears essentially. Whereas if we combine gemcitabine with a high dose of paclitaxel, something similar happens, that we don't see arrest of cells in the G2 and M stage. And in both cases, it looks like the effect of gemcitabine and the arrest of the cells in the S phase is predominant. So how is that going to translate to survival? We used this in vitro washout assay trying to simulate what happens in the clinical setting. So here we added the two drugs to the cells in the culture. And after 24 hours, we washed off the drugs and we continue to grow the cells in fresh drug-free medium. And in 4 weeks, we're going to analyze how the cells survive by either colony formation assay or a measurement of the cell viability by the MTT assay. And this is what we see. With just paclitaxel alone, we see a limited number of cells that can survive the colony forms after 4 weeks. But in the presence of gemcitabine, we see a dramatic increase of how many colonies can survive in this assay. We have similar patterns observed in the measurement of the overall cell viability. So from these studies, I think it suggests that the presence of gemcitabine provides a protective role. And we are very much interested in what is the mechanism involved in inducing the cytotoxicity by low nanomolar paclitaxel. And we wanted to know if we can have ways, either pharmacological means or genetic means, that we can use to manipulate or even enhance the effect of paclitaxel at a lower dose. So to quickly get into this, we get together all the compounds that we have collected over the years in previous or current projects. So this is what we see. So far, we have not really identified any compounds that can enhance the effect, but we do see several others that, similar to gemcitabine, can reduce the effect. I think it still provides some insights on the potential mechanism involved in this. So the first one showing here is cytochalasin B. It is a compound that binds to the actin filament. And one of the major effects in terms of the cell cycle is that it inhibits cytokinesis. And in this case, we also see a reduction of the sub-G1 population that is caused by paclitaxel. And there are several other compounds that I'm showing here, including irinotecan, SAHA, the inhibitor, the HDAC inhibitor, and a couple of protein kinase inhibitors. So in all these cases, what we observed is that these cell cycle inhibitors somehow interfere with the effect of paclitaxel. And but there is a common theme, which is that it appears that the effect of paclitaxel at the low dose requires free progression of the cell cycle from G1S or the G2/M phase, including cytokinesis. Now, we also used fluorescent microscopy to look more closely on how the drugs affect mitosis, and in particular, the spindle formation. And here, I'll just quickly go through this by saying that we observed that in the presence of low-dose paclitaxel, there is an increased incidence of spindles that has 3 poles. We know that usually it has 2 poles and pulls the chromosomes apart to form the daughter cells. Now we have 3 and sometimes 4 poles, and that leads to uneven and abnormal distribution of the chromosomes. And that effect is inhibited in the presence of gemcitabine. I can't see. Yeah, so at the same time, we have a number of siRNAs that we can use. We wanted to see genes and pathways that may be involved in how the cells responds to the low-dose paclitaxel. And one of the genes that we are interested in is survivin. Survivin, as you know, is an inhibitor of the apoptosis family. It also plays a role in regulation the mitotic checkpoint. So we thought at the time it's an ideal candidate, and our hypothesis is that survivin may play a central role in coupling how the cells respond to mitotic challenge and regulate this anti-apoptosis program. But quite disappointing to us, what we found is that when we knock down survivin, we also see a reduction of that sub-G1 population. So instead of enhancing the effect, we actually we saw the opposite. But you probably have noticed that knocking down of survivin also causes a G2/M arrest. So the data, in a way, is consistent with the other findings that suggest that free progression of the cell cycle is required for this effect of paclitaxel. And we have previously developed small molecule inhibitors of survivin, which gave very similar results. And there is one gene that we found when knocked down can actually enhance this effect, and that is YAP. So this is a transcription cofactor and the core mediator of the hippo-YAP signaling pathway. We and works from other groups showed previously that YAP is overexpressed and activated in pancreatic cancer and is implicated in playing a role in how the cells respond to drugs. And in this study, we show that when we knock down YAP, the cells, that sub-G1 population is increased. So this has become a new area of interest to us. So I would just like to quickly summarize with this slides. We see that paclitaxel can induce cell death through at least two mechanisms. One is that at a higher dose, it causes cell mitotic arrest that eventually leads to death, whereas at lower doses, it causes this multipolar cell division, leading to cells with hypoploid cells that does not have the complete genome. But in either cases, the presence of gemcitabine predominantly causes the S phase arrest, preventing this effect of paclitaxel. So I think the study raised the point that when we develop combination therapies that involves reagent that targets the cell cycle, we need to consider if one drug may eclipse the effect of the other. And in terms of the Abraxane and gemcitabine combination therapy, it is conceivable that we may be able to further optimize the efficacy of this combination therapy by trying different time point where we administer the drugs. For example, the drugs can be given sequentially, but maybe we can consider increasing the time interval between the two drugs. With that, I would like to acknowledge the members of the Pancreatic Research Group at Cedars-Sinai. Dr. Pandel has been a long-time mentor, and none of this work can happen without their support and contribution. Thank you.
Okay, really quick, we got to move on.
Yes.
Yeah.
So from your data, I anticipate that you will increase the cell death with checkpoint inhibitors. What do you think about that?
Sorry, with what inhibitor?
I anticipate simply by adding checkpoint inhibitors, by releasing the progression through the cell cycle, you will increase the sub-G1 population or cell death. Do you agree?
I'm sorry, I didn't follow. With what inhibitor?
Checkpoint inhibition. What do you think about checkpoint inhibitors?
I think she's asking about whether they, immunotherapy checkpoint.
With immunotherapy checkpoint inhibitor.
No, with your approach with paclitaxel, and just if you add checkpoint inhibitors, I assume that you will have increase in the apoptotic population.
Yeah, I think that's a good point. It's very likely that you may see some kind of synergy in this. But at the same time, I think we always have a concern on how paclitaxel affects the immune cells. That circulates.
But I didn't mean immunocheckpoint. I meant checkpoint inhibitors,
like
cell
cycle checkpoint inhibitors. I think in most cases it's probably going to interfere with each other.
Yeah.
Some of the compound in the beginning we did not anticipate that there can be this interference, such as SAHA, but we realized that it is something that causes arrest in the G1 and the G2 and M phase. So right now, our study shows this pattern that when you interfere with cell cycle progression, you don't see this effect at the low dose, that is.
Thank you. Thank you, Dr. Wang, for your talk.
It's an important clarification about the checkpoint inhibitors. Okay, two more talks. So we'd like to welcome Shijun Zhao, a postdoctoral fellow at the University of Oklahoma Health Sciences Center. He'll be presenting his talk, Metabolic Reprogramming Promotes Muscle Wasting and Immune Evasion in Pancreatic Cancer.
Thank you for the introduction. Good afternoon, everyone. Today I'm going to share something about our research progress on muscle wasting and its correlation with immune invasion in pancreatic cancer. Okay, I have nothing to disclose. I don't think I need further introduction to this devastating disease. Cancer cachexia is prevalent in pancreatic cancer patients. Over 70% of these patients will have cachexia, which is highest across all cancer types. It is characterized with body weight loss and muscle wasting. Not just skeletal muscle, but all kinds of muscle. Eventually, these patients will die because they cannot tolerate any further treatment. Muscle wasting occurs much earlier than we thought. This study showed that it was initiated anywhere between 6 to 24 months before the diagnosis. And fat loss is even earlier, indicating that even though the tumor size is very small, it can still cause muscle wasting. So with that being said, unless we can completely remove the tumors, otherwise it will continue to drive muscle wasting. But as Dr. Chris Wolfgang said yesterday, only 20 to 30% of patients had the chance of surgery. Most of these patients don't even get a chance for surgery. So what do we do? So we turn to immunotherapy, which has transformed the treatment paradigms for several cancer types. But for pancreatic cancer patients, the response rate is extremely low. We did identify several biomarkers associated with the treatment outcomes of immunotherapy. For example, for those with BRCA mutations, especially BRCA2 mutations, these patients have better treatment outcomes when they receive immunotherapy. And these findings have been validated by many other groups. For example, this study enrolled 12 patients with metastatic pancreatic or biliary cancers, and these tumors have BRCA mutations or similar mutations associated with HR deficiency. After receiving immunotherapy, these 4 patients achieved complete response, and they remain tumor-free after 2 years follow-up. The tumors are relatively gone. But less than 3% of pancreatic cancer patients have these mutations. So what do we do with the other 97%? We found that muscle wasting is associated with worse treatment outcomes of immunotherapy. For cancer types with high cachexia potential, they're less effective with immunotherapy. And this is consistent with a recent study shows that sarcopenia at baseline is associated with worse treatment outcomes of immunotherapy. It turns out probably we need to fix the muscle wasting problem before we can increase the sensitivity of immunotherapy. Actually, our group have been focusing on studying muscle wasting for a while. We identified that a gene transporter named Z4 promotes muscle wasting by stimulating RAP27B, regulating release of extracellular vesicles to promote muscle wasting. And later on, we showed that metabolic stress can upregulate ACS2 Z4 signal pathways to drive metabolic reprogramming. On the one hand, promotes macropinocytosis to increase nutrient uptake. On the other hand, secrete chain to promote muscle wasting and provide more nutrients for tumor cell growth. During this study, we noticed that a group of immune cells increased, which is macrophage. They increased dramatically in late-stage KBC mouse models. So we analyzed their correlation with muscle wasting, and we found that macrophage is associated with cancer cachexia. And we validated in mouse models and human patient samples. Next, we showed that macrophage-derived CCL5 can promote Twig secretion from cancer cells and then promotes muscle wasting. And on the other hand, pancreatic cancer cells can recruit and activate macrophages through the Z4-EXTC CCL2 pathway, basically forming a feed-forward loop. And we established 2 mouse models with macrophage depiction. And we showed that when we deplete the macrophage in tumors, and you will reverse muscle wasting and increase the grip strength and decrease the biomarkers associated with muscle wasting, and also increase the cross-sectional area of muscle fiber. So basically, this study identified crosstalk between the tumor cells and macrophages that promotes muscle wasting. So we show that several key cytokines driving this process, including CCL2, CCL5, and Twig. And interestingly, a recent study from Dr. Stevenson's group at MD Anderson showed that tumor cells can secrete CCL2, which promotes neural inflammation and activates the vagus nerve and leading to the dysfunction of liver metabolisms, which will promote food intake loss and cachexia. One of our recent studies also showed that for patients with liver metastasis, they are less responsive to immunotherapy compared to those with other metastases. This is consistent with a recent publication showing that liver metastasis actually restrain the treatment response of immunotherapy in multiple cohorts of patients. Other ongoing projects in the lab also studied the neuron systems involving in cachexia. We show that GDF15 can drive muscle wasting by shifting the fuel utilization pattern from using lipid acid fixation towards using carbohydrate. And when we brought the GDF15 pathways using the inhibitors and mono antibodies, we found that it will attenuate pancreatic cancer-induced muscle wasting. This is consistent with study shows that GDF15 level is associated with reduced efficacy of immunotherapy in patients. We know that most clinical trials trying to target muscle wasting have failed, but this one have shown some promising results. This is the antibody targeting GDF15. And right now it has entered phase 3 clinical trial. And also targeting GDF15 also shows synergistic effect with immunotherapy in solid tumors. And other ongoing project showing that aerobic exercise and IL-15 secretion can sensitize pancreatic cancer to immunotherapy. We also saw that IL-15 level decrease in both the muscle tissues and the tumor tissues in pancreatic cancer patients, mouse models in multiple cancer types. And the mechanism study shows that IL-15 can promote immune infiltration and decrease immune senescence, then promotes the the anti-tumor immunity. To summarize, cancer cachexia is a complicated and systematic dysfunctions that involves multiple organs. We show that tumor cells can secrete TRIG and J and other cytokines to promote muscle wasting, which will decrease the level of IL-15 and leads to immune invasion. On the other hand, it can also secrete CCL2, GDF15, and target the central nervous system and leads to the dysfunction of liver metabolism, and then leads to immune invasion, which promotes muscle wasting, thus forming a feed-forward loop to promote cancer cachexia. With that, I would like to express my gratitude to our team and all the members of Lee Lab and our collaborators across the nation and globally. Thank you very much for your attention.
Thank you, Dr. Zhu. We are short on time. We will ask the audience to ask you questions at the end. Okay. Thank you very much.
Thank you.
I'd like to invite Dr. Kian Yu for the last talk. Dr. Yu is an assistant professor at the affiliated hospital in Qingdao University. She will be discussing the spatial landscapes of metastatic pancreatic cancer associated with fat liver disease. Welcome.
Thank you, Dr. Buckney, for your introduction. I'm very glad to be here today and share some of our latest research with all of you. Sorry. This one. Okay. Okay, so over the past 3 decades, the overall pancreatic cancer survival rates has improved from 4% to 30%, while the metastatic pancreatic cancer survival still remains at the same at around 3%, and establishing liver metastasis as a major therapeutic challenge. So during my PhD study at Hong Kong University, I mainly investigated fatty liver disease, which we now call metabolic associated fatty liver disease. But when I started working in the hospital, we observed that liver conditions affect cancer therapy response and prognosis. And very interestingly, more than half of pancreatic cancer patients who have surgery develop fatty liver disease within 12 months postoperatively. And emerging mechanistic insights into fatty liver-driven colorectal cancer liver metastasis have been revealed recently, including one paper published in Cell Metabolism in 2023. Yet mechanistic links to pancreatic liver metastasis still remain underexplored. So in our previous research, we established a critical link between fatty liver disease and pancreatic cancer liver metastasis, first through cohort studies in the UK Biobank, as well as retrospective clinical data confirming its association with liver metastasis. And mechanistically, we identified macrophage inhibitor factor and CD44 axis in the fatty liver microenvironment reprograms immune cells and fuels metastasis, a finding validated in multiple preclinical mouse models, as well as in human samples. And this work is currently under revision in Journal of Signal Transduction and Targeted Therapy. So building directly on this foundation, we next ask what are the spatial landscapes of fatty liver associated pancreatic cancer liver metastasis. To address this, we leveraged high throughput MRA and protein analysis. And for MRA profiling, we used high resolution spatial transcriptomics. And at the protein level, we used image mass cytometry, a technique that uses metal tagged antibodies for highly multiplexed tissue imaging. And to ensure accurate and reliable results of the cellular annotations, a multi-step approach was used, including mapping of the major cell markers and deconvolution analysis, as well as imaging mass cytometry to corroborate the cellular annotations at the protein level. And then, inspired by a paper published in 2024 in Nature Genetics, we leveraged both ISKIA and Banksy, which are two computational methodology to identify cellular neighborhoods. So ISKIA is a concept derived from ecosystem, and it treats cell types in the tumor microenvironment as analogs to species in the ecosystem, and it treats tumor tissue regions as habitats, ecological habitats in the ecosystem. So by analyzing which cell types co-occur or avoid each other, it infers functional and structural units within the tissue. And Banksy is another common method for investigating spatial transcriptomics, and both methods enable us to reconstruct tumor microenvironment structure based on the spatial co-occurrence as well as cell interactions within each spot. And we call this architecture tumor spatial ecotypes. So we identified a total of 20 ecotypes in our samples, and they show good correlation with the HE histopathological structures. So for example, the echo, can I point this? No, okay. So for example, echo type 4, we could clearly see that it located in the tumor border. And for echo type 0, it is distributed in the hepatic parenchyma. And also in fatty liver samples, the same, we identified also 20 echo types. And next, we grouped these 20 echo types into 5 key zones, including tumor, niche, stroma, tumor border, and hepatic parenchyma. And when comparing the control and fatty liver samples, we observed both shared and unique echo types within each sample. And we are particularly interested right now in this echo type 5 and 11 echo types, since they are showing very interesting structures. So here we could see that echo type 5, which is labeled in red, surrounding the echo type 11, which is marked in yellow. And we then dug deeper into the cellular constitutes of these echo types. And we found that in echo type 11, they have very enriched cancer-associated fibroblasts, as well as various types of immune cells. And then we further analyzed the key GG pathway enrichment. And we could see that echo type 5, which is located in the outer layer of the tumor foci, showed increased cell adhesion molecules, while in echo type 11, which is located in the inner space, exhibited enrichment in chemokine signaling pathway, as well as natural killer cell populations. And this spatial organization suggests that NK cells might be actively engaging tumor cells in this tumor foci. And more interestingly, when we look at the right side of this slide, when we look at the fatty liver samples, we found that NK cells were predominantly excluded to the tumor border. And this might suggest a unique spatial feature of fatty liver associated liver metastasis. And now we are investigating whether this NK cell marginalization contribute to the impaired efficacy of liver metastasis in the fatty liver microenvironment. And last, we want to emphasize that in previous study, including the paper published in Nature Genetics in 2024, they used spatial transcriptomics at a resolution of 55 micrometer. And we also applied both methods at the same resolution, but the results were unsatisfactory. So either the spatial patterns appear to be chaotic and indistinct, or only a limited number of echo types could be identified. So in contrast, employing the latest and high-resolution spatial transcriptomics with 2 micrometer resolution enable us to successfully delineate and distinguish 20 echo types in our samples, which will correspond to their HE histopathological structures. And none of this would be possible without our incredible team. And I want to thank APA for the invitation, and special thanks to Professor Saluja and Professor Ming Li for their essential help with our research. And I also want to thank Professor Pando. Actually, 5 years ago, your grant actually inspired us into this, this project about how fatty liver and pancreas initiates the cancer progression and metastasis. And thanks for listening.
Time for maybe one question.
Beautiful work. I really enjoyed your talk. Your platform is 10x Genomics?
No.
For spatial transcriptomics.
No, we actually collaborate with companies and we did it together.
So you invented a new technique.
I'm sorry?
Which platform did you use for the spatial transcriptomics?
I think the 10x.
10x.
10x, yes,
Okay,
yes, yes. But we do collaborate with team in Chinese Ocean University, and all the echo types were analyzed by their team. So the company just gave us the data, and we then analyze it with another team.
So those techniques that you described that have acronyms like Banksy.
Yeah, these
those
actually are published.
Techniques that you overlaid on the basic data
Mhm.
to identify spatial neighborhoods.
Yeah, actually, these methods are available in public, but no one has been using this method in high resolution transcriptomics. So that's what we did.
I see. Thank you.
Yes, thank you for your
Very
question.
nice to know.
Okay, thank you. Can we thank all the speakers again for a wonderful session? Oh, we have one more speaker.
I promise you're done for the day, but I just want one administrative detail. Just please come to the reception and the dinner, and please have your colleagues come to the reception and dinner. That will start reception at 7 p.m. It will be kind of outside here. Dinner will be in this room starting at 8 p.m. and we will have the awards and a delicious dinner, and promise to try to keep it efficient so you have time to speak to each other as well. So thank you for the great day.